Hi, everyone. Welcome to the University of Toronto Joint Centre for Bioethics seminar series. I'm Rashad Raymond, and at the University of Toronto, I'm a doctoral student in the Department of Philosophy and collaborative specialist in bioethics at the Joint Centre for Bioethics. It is my pleasure to be moderating today's seminar. Our speaker is Dr. Amy Mullin, and her talk is entitled Dementia, Care, and Respect. Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics YouTube page. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. The Joint Centre for Bioethics wishes to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and the JCB is grateful to have the opportunity to work on this land. Now it is my pleasure to introduce today's speaker. Amy Mullin is Professor of Philosophy at the University of Toronto, Mississauga, and Director of Graduate Studies for the Department of Philosophy. She is supervisor or advisor for a number of students in the collaborative specialization in bioethics, myself included. Her research interests include children and autonomy, the ethics of relationships characterized by mutuality but asymmetry, and connections between art, politics, and morality. Amy, on behalf of the JCB, welcome to today's seminar.
Thank you so much, Rashad, and I am delighted to be here. I'm going to be putting up a PowerPoint, and that has worked. So thank you everyone so much for having me here to talk to the Joint Centre for Bioethics. I am delighted to be here, and I want to say that this topic is very new to me, although I have worked on a lot of things related to what I'm going to be talking about today. I've worked on gratitude, I've worked on autonomy. I have not yet worked on kind of philosophical analysis of the situation of people with dementia. So my topic today is going to be kind of my overall argument is that healthcare decision-making for individuals with dementia should happen in the context of thinking more broadly about what makes for caring relationships with them. I will argue that feminist care theory can provide some relevant insights as to how to do this. And one thing that should be clear is that I'm going to be emphasizing care for people living with dementia rather than end-of-life care, although of course that's a very relevant topic. So the structure of my talk is first I'm going to define some terms, then I'm going to characterize the existing philosophical debate about healthcare decision-making for people with dementia. I'm going to indicate what I think are three relevant insights from feminist care theory, and then I'm going to apply those insights to the topic of people with dementia. So why do I talk about feminist care theory and why not care ethics? Well, I think calling it care theory is more inclusive of the political dimension of care than calling it care ethics. Care theory stresses both the ethical and political significance of relationships of care. And for care theory, caring relationships are central, but certainly not sole importance to morality. Justice matters too, including with respect to who cares and who receives care. So when it comes to care, that's a very complicated topic, and the word kind of to care for or care and caring is used in a number of different ways. So when we're talking about caring as an activity, it's the activity of seeking to meet someone's basic needs. I'll take this definition from Daniel Engster's work. Care can also be an attitude. And it's what I'm interested in what Robin Dillon calls care respect. This is attentiveness to someone's basic needs, but not only with a focus on their needs, but also the perspective of the person with the needs. Ideally, the two are combined so that caregiving involves respectfully trying to meet someone's basic needs. Caring about, by contrast, is having something significantly and stably matter to a person over time. Autonomy, oh my goodness, there could be so many slides just about the topic of autonomy, but autonomy for me is self-governance in keeping with personally meaningful cares and commitments. So there's two aspects. There's the self-determination aspect involved in understanding options and making decisions, but there's also the authenticity aspect in that you can't self-govern in keeping with personally meaningful cares and commitments if you don't have any. So we also have to have authenticity in terms of relative stability in that dimension. Now, there is certainly widespread agreement about the importance of respecting the self-regarding decisions of autonomous people. There's a lot less agreement about what exactly autonomy is. Is it relational? Is it substantive or procedural? What's the role for critical reflection? And I'll just very briefly say that my view is one of relational autonomy. So I think that autonomy is not only developed in our relationships with others, but also can be sustained, recovered, maintained, and unfortunately also can be undermined in virtue of our relationships with others. Mine is a weak substantive approach to autonomy in that I think that in addition to skills and capacities required for autonomy, we also have to have attitudes. So we have to have hope and self-trust. And in terms of critical reflection, I think it usually helps, but is not required for autonomy. And in kind of work I've written about children and autonomy, I've argued that children can have local autonomy in some domains, even when they don't have fairly advanced capacities engaging in self-reflection. Dementia is cognitive decline in at least two of memory, judgment and understanding, orientation and awareness of one's surroundings, attention, language use, complex motor skills, and personal care. Most people think that dementia always involves a loss of memory, and it typically does, but it's not always the case, so long as there's a decline in two of those other dimensions. So what I'm going to do now is turn to the major existing positions in the philosophical debate about healthcare and people with dementia. So I thought it was kind of nice that this is the 30-year anniversary of Ronald Dworkin's book, Life's Dominion, in which he developed a very influential position on autonomy and dementia. For Dworkin, people with full moral status have not only experiential interests or sort of short-term enjoyment, but also critical interests. For Dworkin, critical interests are things that can be evaluated. Fulfilling them genuinely makes a person go better, even if they aren't aware that they've been realized. One example of a critical interest for Dworkin is autonomy, and other examples are fulfilling interpersonal relationships and successful contributions in one's career. Critical interests for Dworkin require a person to have a perspective on their whole life, which people with severe dementia lack. Continuing to appreciate one's interests as values which have a standard of correctness and in light of a perspective on one's whole life are challenged or frequently undermined in the case of dementia, at least when it's severe. And for Dworkin, without critical interests, a person doesn't have full moral status. So for him, when dementia has progressed and a person no longer has a perspective on their life as a whole or critical interests, he says the way that we should interact with them is we should be guided by the critical interests of their previously competent self. And for Dworkin, the only autonomy left to respect in people with significantly developed dementia is precedent autonomy. For him, advanced directives should be followed when available, and when they aren't available, substitute decision makers should be guided by the dementia patient's previous critical interests. One thing, and maybe this is a bit kind of snide of me, but he doesn't notice that or doesn't observe that women are overrepresented both in patients with dementia and as their caregivers, both paid and unpaid. So there's a famous case of a 50-year-old woman with dementia named Margot that Dworkin discusses. A medical student who spent considerable time with her described her as one of the happiest people he knew. She enjoys painting. Dworkin observes that they weren't great works of art and that the paintings declined in skill over time. She enjoys reading mysteries, and Dworkin notes that her bookmark was inconsistently placed in the books. She enjoys eating favorite foods, being with loved ones, and being held by them. Dworkin says that Margot is severely demented and she no longer has critical interests. So the only way to respect Margot is to respect her precedent autonomy. And Dworkin considers up to half of all people over 85 as having not just dementia, but severe dementia. This view of Dworkin's is what Emily Walsh in a recent article calls the received view. This is the idea that people with dementia have only precedent autonomy, in that their formerly competent selves might have had autonomy, but they no longer do. Some contemporary examples of this view are Norman Cantor and Daniel Grohl. And the implication for many persons with dementia is that they are excluded from the possibility of having interpersonal relationships on this view. They become objects of managing care, whose experiences should be as pleasant or lacking in pain as possible, and any advanced directives about not providing treatment or withholding life-sustaining treatment should be followed, regardless of the person's present views. Dworkin's critics include Rebecca Dresser. So Rebecca Dresser argued that people with dementia can continue to care about things and that their treatment should be guided by what she terms their best interests, and that best interests involve taking what they care about into account. So this was an article she published in 1985 with the title Dworkin on Dementia, Elegant Theory, Questionable Policy. But as recently as last year, she continues to maintain the same position. She points out that people with dementia can care about maintaining previous relationships and starting new ones, whereas Dworkin suggests that people with severe dementia, which is how he labels Margot, cannot maintain or start interpersonal relationships. So he disregards the information about her enjoying spending time with the people that she loves and being held by them. Dresser also suggests that people writing advanced directives can often fail to appreciate the idea that their future selves, those future selves who have developed dementia, could still have interest worth taking seriously. Now, Dresser is one of several theorists who argue that Laurie Paul's concept of transformative experiences might be relevant to thinking about the way a person's interests may shift with dementia. Two other theorists are Borsler and Walsh in 2020 and in 2017, respectively. The previous strategy with respect to thinking about the applicability of the kind of pre-dementia person's critical interests and their values was to claim that the person with dementia has changed so much, perhaps, that they're no longer continuous with the past, and so it's inappropriate for the kind of past person's views to be applied to them. Now, the newer strategy is to talk about the concept of transformative experiences. Laurie Paul argues that prior to experiencing a transformative experience, and her fanciful example is becoming a vampire, her more realistic examples are becoming pregnant or raising one's first child. But Paul argues that before these transformative experiences, we don't have rational access to how our preferences and interests and attitudes will change. And so what Dresser is doing is sort of saying, because this is developing dementia is a transformative experience, this means that we shouldn't be applying the views of the person before they develop dementia to the person who has dementia. I think that the concept of transformative experience is perhaps too strong here. I think we do have some reliable information about how preferences and attitudes change for many people with dementia. For instance, relationships often become more important. But the takeaway is that interests will predictably change, as, for instance, they do when people develop disabilities. And people who develop disabilities often find their lives more rewarding than they thought they would have previously. So the kind of takeaway here is the idea that we should not discount the importance and meaningful of new interests acquired by the person with dementia. One of the philosophers who's taken most seriously within this debate is Agnieszka Jaworska, who developed her views originally or published them in 1999 in an article called Respecting the Margins of Agency, Alzheimer's Patients and the Capacity to Value. And Jaworska agrees with Dresser that many people with dementia, fairly advanced dementia, can still have the ongoing capacity to have interests that should be respected. And she thinks that even if they might no longer value things in Dworkin's sense, which required a standard of correctness, a whole life perspective, they can still value things in a less demanding way. In 2007, she shifted her views to sort of focus not on an undemanding sense of valuing, but instead more directly on the notion of caring. And that's what I'm going to be focusing on in my talk. But as her views develop, she argues that people with dementia, even fairly developed dementia, can have their autonomy assisted. So Jaworska also says that one of the reasons she cares about saying that people with dementia can have continued partial autonomy and assisted autonomy is because she thinks this is grounds for their full moral status. So for her, people with dementia can have full moral status because they can still have authenticity, stable cares, or values that others can discover and then use to guide their care. She points out in more recent work that this is in keeping with feminist theories of relational autonomy, that our relations with others are vital to developing autonomy, sustaining it, and recovering it. But she also recognizes that her conception of autonomy stretches it pretty far, especially in connection with self-determination, because she's insisting that people with dementia can still have stable cares or values, but it is often difficult for people with dementia to engage in self-determination because of some of the kind of problems they can have with respect to memory, judgment, orientation, understanding, attention, and I would add self-trust. This can really challenge their ability to direct their life in keeping with what they care about. And I agree with her that it is very valuable to have other people help shape the environment of someone with dementia and relate to them in ways that reflect what the persons with dementia care about. But I do think that tying full moral status to autonomy is shaky ground. Instead, I think that the full moral status of many people with dementia can be tied more directly to their ability to care about things and people. So the idea that people can still be persons with whom respectful relationships are appropriate, even when they no longer are autonomous, is my kind of person's care view of people with dementia. So the person's care view is consistent with findings that people with dementia want the care they receive to reflect what they care about, often more than their caregivers realize. Care for people with dementia should, in fact, I think, reflect what they care about, even when they no longer can self-govern in central areas of their lives. I would agree with Jaworska that when they can be autonomous with assistance, that assistance should be provided. But when they cannot, I think their care should be governed by recognition of their personhood and awareness of what they care about. I also think, and this is something that is very, I think, not paid enough attention to in kind of the existing philosophical literature, that the contributions of their caregivers, both paid and unpaid, to their relationships should be recognized and enabled. So caregivers, I think, should interact with people with dementia as persons who are worthy of respect, and not have the terms of their interaction and the care that's either provided or denied be dictated entirely by the views of the person before they develop dementia. My person's care view reflects the dual capacities of many people with dementia to care about things with considerable stability and to be in caring interpersonal relationships. And as I already mentioned, I think we should think more about the role of their paid and unpaid caregivers. So now I turn to the middle section of a talk when I talk about what I think are relevant insights from feminist care theory. There's three. The first is the importance of reflecting on both the ethical and political nature of relationships of care, the famous slogan for feminism that the personal is political. Daniel Engster and Joan Tronto are two examples of feminist care theorists, and feminist care theory really emphasizes the importance of discussing the fair distribution of benefits and burdens associated with caring relationships. So factors such as sex, age, race, ethnicity, social class, and global location all have a huge impact on who cares and who receives care. Also, this was drawn kind of to my attention only kind of really in the past week or so, but Janelle Taylor's work on kinless people with dementia emphasizes another factor that can be really important in determining the quality of care and the type of care the people with dementia receive, and that's whether or not they have kind of partners or spouses or children who are highly involved with them, who help shape the nature of the care that they receive. Asha Bandri is another example of a kind of feminist care theorist who I think gives a nuanced account of how people's social locations inequitably shape both who cares and who receives care. So who does care and receive care? Well, women are overrepresented as caregivers of people with dementia, and they are also overrepresented in the people needing such care. This is from a recent study in the US of the kind of paid work care workforce. Older adults of color in the United States are more likely to need assistance in daily living than their white counterparts. And the direct care workforce in the United States is 86% female, 59% people of color, and 26% were born outside the United States. So the second important insight from feminist care theory is that we need to pay attention to the needs and capacities, both of those who are giving care and those who are receiving it. There is a danger of paternalism, and the importance of paying attention to the needs and perspective of the care receiver was something that Joan Tronto insisted on in kind of her book published 30 years ago. Uma Narayan offered a early and a very important criticism of kind of the tendency of feminist care ethicists at that time not to pay enough attention to kind of care in a global context and to think about the differential vulnerability of people who give and provide care in that context. Eva Feder-Cates focuses on the social responsibility to provide people with heavy caregiving responsibilities with support, both for their own needs and help meeting the needs of the people in their care. So some examples of kind of taking this kind of approach and with respect to care providers is the need to attend to the point of view and needs of care providers and their vulnerabilities, including, again, those who are providing paid care. So I have talked about this in kind of work I published over a decade ago, and Monique Lanois in work published even a few years before that. I think that the best caring relationships involve what feminist theorist Robin Dillon calls care respect. Care respect involves appreciating another person as a specific individual and responding to them in their concrete particularity, recognizing that they have a perspective, seeking to understand the world from their point of view, and recognizing that they have both needs and capacities. Dillon insists that autonomy is not required for care respect, and I certainly agree. The third insight from feminist care theory is that selves are relational. So this is true not only of autonomy, as I mentioned, my theory is one of relational autonomy, but it's also other important capacities are developed in relationships and maintained or undermined in relationships. I think the capacity to be in a caring relationship, whether you're providing care, receiving it, or both, is morally important. And this capacity should be developed, maintained, and restored whenever possible. I don't think that passively receiving care is morally valuable if you don't even recognize another person is providing the care for you. But I do think the ability to value another person and they provide is. This is something I argued in something published in 2011. So now I turn to the section of my talk devoted to applying these insights from feminist care theory to thinking about relationships with people with dementia. People providing care for people with dementia, whether they're unpaid family and friends or paid direct care workers, have the potential to be in caring relationships with them. And indeed, these may be some of the few remaining caring relationships available to people with dementia. So I think it is really important that caregivers are empowered to interact with them as they currently are and to meet the needs of the people before them, rather than to have the terms of that care dictated by what the person would have wanted before they developed dementia. So I think substitute decision makers should seek information always in making healthcare decisions about the perspective of the current perspective of the person with dementia, seek insights from their caregivers, both paid and unpaid, and recognize also that caregivers need to be given the opportunity to relate to the people in their care as people, rather than being governed solely by the critical interests of the person before they develop dementia. I do recognize there can be an important role for advanced care planning, but I think it should be flexible. And caregivers who might be expected to withhold life-sustaining treatment from people with dementia who still enjoy living could experience moral distress. There's an important difference, I think, in the relationships that people who knew the person with dementia before the onset have with the person with dementia, as opposed to those who only came into their lives after they developed dementia and needed significant care. And I recognize that people who were family and friends before the onset of dementia can experience, and often will, some grief at the loss of the capacities of the person, the shifting nature of their relationship. Their interaction is understandably shaped by what the person was like before. But I think that there's an example that Jaworska gives that troubles me somewhat. So this is an example of Julian, who was a renowned scientist, and there is going to be a banquet given in his honor. He now has significant dementia, and he still can express his thoughts, but he doesn't always do so in a very kind of clear way. And his wife, Anne, who wrote a memoir about their time together, knows that Julian really wants to give a speech at this banquet that's held in his honor, but she is concerned that he would not make a very coherent speech. So she listens to him and she writes down his thoughts, and then she gives a speech in his instead of him. And Jaworska gives this an example of assisted autonomy, but I guess, and I don't know more of the details, but I was wondering whether this might also be an example of Anne's attempt to preserve the memory, at least for the audience at the banquet, of who Julian used to be. And caring for someone with dementia can definitely, often will, involve respect for who they used to be, but I think it also needs to reflect who they are now and what they care about. So I wonder if it might have been possible to allow Julian to kind of give the speech himself and to supply any missing information afterwards. Another alternative is that one very respectful way of interacting with people with dementia is often to use videotape, so they can kind of look at what they're saying and pause and rewind and reword things. And so I do think that it's a danger for people who knew the person who they used to be before they developed dementia to project very much their preferences onto people with dementia. This is something that Wilkins et al. Talk about in 2022. And I think that there are opportunities sometimes for a little bit more clear-sightedness from the people who are interacting with people with dementia who only came into their lives once they developed it. I think that Hilde Lindemann's work about holding in personhood is really relevant to the way that I would like to think about healthcare decision-making for people with dementia. Holding someone in personhood for Lindemann is not necessarily maintaining the person in autonomy, but instead she speaks of a granddaughter painting her grandmother's nails red when the woman can no longer do so herself, and of the granddaughter's father, the son of the woman with dementia, sitting and having his mother scratch his head the way she has all her life. These are not examples of restoring autonomy to someone, but instead maintaining relationships, maintaining habits and activities that were and continue to be meaningful to the person with dementia. And I think it is really important that ways of holding someone in personhood should still be meaningful to that person, because otherwise anyone seeking to hold someone in personhood is locating that personhood entirely in the past. I also think that there can be an important role for creative art making in holding people in personhood. So Anne Basting, who is a academic and a practicing artist, describes her work with the Penelope Project, which involved going into a long-term care home in which people with both mild and very significant dementia were residents, and the artists and students kind of worked with the caregivers working in that home and also the residents themselves to develop, kind of co-create a work of art and to perform it. One Penelope Project interviewer asked a skilled care resident, which means someone who required very significant care because of her dementia, what she thought of participating in the project, and she responded, "It is the last important thing I will do in my life." That's a project in the United States, closer to home, here in Canada, and with a U of T researcher. Art can be a means of reclaiming the citizenship of people with dementia, ways in which people with dementia can contribute to their communities. It doesn't have to be a kind of short-term activity, kind of arts like kind of make work arts and crafts, passively witnessed by people, but instead they can be co-creators. One thing that's important about the arts is that they don't always have to be verbal. So people who might struggle to communicate verbally can still dance or move and respond to music. When arts activities are performed for publics, they can destigmatize people with dementia and combat the kind of tragedy discourse that there's no self left. And do we all note that people with dementia and their loved ones remember in engaging in these kinds of art projects that they have capacities and there are new possibilities for the future, not just loss. Now, James Wilkins develops an approach to medical decisions for people with dementia that is in some respects in harmony with my own, but I think he goes in a kind of more specific direction that would only sometimes be appropriate. His is called the narrative interests approach, in which, where I agree with Wilkin is I don't think you should focus only on what the person previously wanted, whether there's an advance directive or reconstruction of the person's preferences by substitute decision makers. I also don't think we should only think about how to impersonally benefit or avoid harming them. When preferences change, I think new ones should be given weight. So all of that I agree with. My kind of concern is for Wilkins that the way to do this is that kind of the doctor and the person with dementia and their family should try to recreate the story of the person's life, and they should talk about the plot, the narrative structure, the voice, and the characters. I think this might be very helpful for some people, but I think it also can overvalue narrative continuity in the telling of one story. Not everyone wants to have a narrative of their life as a whole. That's very much kind of what Dworkin thinks we should be doing, but not everyone who is capable of kind of fully capable of autonomy wants to have a narrative of their life as a whole or wants to have only one narrative. Sometimes the past is going to matter to the person with dementia, but sometimes it's going to be more important to focus on their current interests. And I think what we need to do is take our cues from the person with dementia and those who interact with them. And I also, as I observe, sometimes paid caregivers can focus a little bit more easily on the present reality, as their relationship with the person only typically started once they had dementia. So the upshot for healthcare decision making is that one common decision that needs to be made is about discharge from a hospital setting for a person who previously was cared for at home. And my approach would recommend that we focus on what the person's preferences are now, but in light of their overall preferences and values and not simply the desired outcome. I have been there. I have heard kind of, people say, I just want to go home. And sometimes that just isn't possible, or the person isn't aware of what would be required for them to go home in terms of the unpaid labor of others. So I think it's really important to explore things like, do they value maintaining existing relationships? Do they want to have options for new relationships? Do they value the well-being of their unpaid caregiver? Are there options for assisted living facilities where paid caregivers will actually have time to meet their social needs, where activities of interest to them are offered, where family caregivers can contribute to care, where privately paid caregivers might supplement the institutional care? Are there good options for supports for the in-home care, for additional unpaid caregivers, for a daycare program, for respite, for paid caregivers to be employed? And I think in all of this, the prior views of the person with dementia may be relevant, but this is not, for one thing, an entirely self-regarding decision, and their prior views may not have reflected an accurate view of their future needs and their future options. I think when we're thinking about care respect, we need to think a lot about the capacities of care receivers. I think we need to find ways to remind a loved one with dementia of how they can still contribute to their relationships, and more broadly, what they can still do. Some ways in which people with dementia can still contribute to their relationships include paying compliments, expressing gratitude, sharing hugs, listening to music together, making jokes, offering hospitality in ways that are easy for them to do, like offering an apple or a glass of water. People with dementia can still make contributions to their relationships, and they can still, I think it's really important to recognize their interest in doing so and their ability to do so. I think that's part of care respect. It's also really good for them to have opportunities to do this outside of their closest caregiving relationships. If the only person who recognizes that they're still a person is kind of their caregiver, then that also puts a really heavy demand and burden on the caregiver. So those who can recognize that they're receiving care and that a person is providing it also, I think, have a responsibility to respond respectfully. So I've already said this before, that I think that paid caregivers have an opportunity to kind of provide and share clear-headed insights into the current needs and capacities of a person with care. But this is only if time is made available, if they're only allowed to pay close attention, the kind of close attention that's required for care respect. And caregivers should be given an opportunity to interact with the person in their care as a person, not merely a body needing management. So Monique Lenoir talks about being given, a paid caregiver being given 4.5 minutes for a shower, 45 seconds to adjust the person in their care to prevent bed sores. And that kind of very highly regimented care can make it very difficult for people who are providing care to interact with the person that they're caring for as another person and not merely a body in need of management. So I wanted to now kind of draw upon that kind of report on the composition of the care workforce in the United States that I mentioned and provide some quotes from paid caregivers. So one is Desalene Watkins, who writes, "My relationships with my residents are multifaceted. Yes, I'm their staff and my job is to report them, but I'm also a mentor, a friend, and I provide guidance. The residents are also here for us. If I come to work and I'm not in the best mood, they make me feel better and are concerned for me as well." Kulix Avibinel says, "Our members appreciate the simple things we sometimes take for granted. When they tell me, thank you for the hug, or thank you for smiling, I know I did something right to make them happy, and that makes my day." I think these are both examples of people who recognize what philosopher Jeanette talks about, which is that there should be a difference between our assessment of someone's current capacity for autonomy and the possibility of engaging in a social relationship with that person. And one way, I think, in which we can kind of recognize one another's kind of humanity is through gratitude. I think that gratitude is a warranted response to benevolence plus respect. And gratitude is merited even when someone's motives are mixed and include working for pay, so long as the motives include a desire to benefit the person and their interactions are consistent with respect. I don't think that care recipients should be pressured ever to be grateful for care, especially because they so often receive disrespectful care. Peter Ashley is a person who has dementia, and in his kind of article, "This is My Life," he talks about another patient with dementia being pressured by his wife to express gratitude, and that people shouldn't be pressured to do so. And I certainly agree with that. But although I don't think people should be pressured to kind of express gratitude, I do think that when they can recognize that they've received kind of benevolence and respect, that it is morally appropriate for them to respond with gratitude. Now, Dworkin argues that near total dependence reduces the value of a life. He says, particularly when a person doesn't recognize that they've received care and can't be grateful. What I think is that we need to be really careful not to be too quick to conclude that people with dementia can't be grateful, and we should be open to evidence from the people who care for them. When people are receiving respectful care and they are capable of gratitude, I do think it's a moral failing when they aren't grateful, especially when they are instead disrespectful to their caregivers. But it's always hard to tell whether a person is or not capable of recognizing that they have received respectful care. Their Dementia Friends is an important initiative that talks about ways in which we can learn from people with dementia. Dementia Friends seeks to educate people. So in one kind of recent initiative, they sought to educate people who are studying to be health professionals about both the losses and capacities that people with dementia have. And this initiative improved the attitudes and led people, when they were health professionals, to develop plans to improve communication and promote the quality of life with people with dementia. Alsawi and colleagues conduct research with rather than on people with dementia. This is in keeping with Tom Kitwood's approach, a psychologist who wrote an important book about dementia. And they, when you interview people with dementia, they really value other people empowering their communication, especially when it's sometimes difficult. They talk about ways in which their communication is empowered, is involving shared opportunities for emotional connection, laughter, feeling heard, not being dismissed or unheard or expected to follow a script. And if you look at the title of their article, is taken from involves a quote from one of the people with dementia who says, "It's nice to think somebody's listening to me instead of saying, oh, shut up." And I certainly have witnessed people with dementia being told to, oh, shut up, by people who are supposed to be caring for them. If there's one thing that I'd want you to take away from my talk, it's that dementia is not a second childhood. We often talk about people who are elderly and who need kind of assistance with some of the activities of daily living in the way that a child would as entering into their second childhood. And there's an article by someone who's providing advice for caregivers of people with dementia that kind of almost falls into this trap, but also sort of seeks a way to avoid it. She writes that for people who are trying to learn to become a caregiver of someone with dementia, a person can quickly learn how to be a dementia-capable caregiver by applying what is already known from childcare, while always being mindful to never treat an adult like a child. I think it's really important that people with dementia are adults. They recognize disrespect. They and their relationships have histories. And even when they may have forms of dependence that we associate with childhood, that they are not children. And I think it is a very big mistake to think of them as in their second childhood. I now want to just sort of sum things up because I want to make sure that there's time for discussion, and I'm aiming to end ideally at 4:40. So I reject the only precedent autonomy view of people with dementia, both for healthcare treatment and for caring relationships more broadly. I certainly recognize that the former is more controversial. If I had to choose, I would certainly prefer the continued partial autonomy approach of Jaworska because it gives weight to the present preferences of a person. But I think it is more defensible to adopt the person's care view, informed by insights from feminist care theory about what's involved in care respect, the needs and capacities of those who give and those who receive care, the role of relationships in sustaining personhood, and the idea that moral status is not undermined by loss of the self-determination aspect of autonomy. Dana Howard, in an article about deciding for the incompetent, writes that presumption of respect for the self-regarding choices of autonomous people should not imply disrespect for the self-regarding choices of those who are no longer competent. Preferences can provide substantive guidance, even if not authoritative guidance. And I do think that both relationships with and healthcare treatment of people with dementia can be informed by who the person was before, but needs to respond to who they are now, and along with insights from caregivers who interact with them with care respect. I think that reactive attitudes such as gratitude and resentment are appropriate in interpersonal relationships. What the person is grateful for or resentful can provide important insights into how to interact with the person with dementia as a person who cares. And as an aside, I think that David Shoemaker's work on the importance of thinking about reactive attitudes to interpersonal relationships for people with compromised autonomy can be an important resource in thinking about what it is to have a meaningful interpersonal relationship with a person with dementia. And I wanted to end by talking about concrete examples. So Margot, for Dworkin, has severe dementia, no critical interests, and no longer has full moral status. For Jaworska, Margot has full moral status insofar as her autonomy can still be assisted. Jaworska and I agree that Margot can still care about things and is still capable of relationships. But where I differ from Jaworska is I think that Margot can have full moral status even if her autonomy cannot be assisted. And I also think that there are morally valuable capacities beyond autonomy that need relational support. I think that they can happen through interpersonal relationships, but there's also other ways of enabling people's morally valuable capacities, including through arts activities. And Mr. Gray is an example that Jaworska gives of an individual with fairly developed dementia who used to be kind of an important executive. And she notes that his nurses have recognized that Mr. Gray is much more cooperative when the nurses ask him to assist them. So if the nurses just say, we have to take your blood, now he might resist. But if the nurses say, would you help us to care for you by taking your blood, then he is cooperative. And what Jaworska says is this is an example of very sensitive care on the part of the nurses. I think this is right. But also I think that there's something important here to honor about what Mr. Gray is doing and his desire to be a benefit to others and and his genuine gratitude to his nurses for their thoughtful care. Finally, Desaline Watkins, I want us to kind of keep in mind her and other kind of paid and unpaid caregivers and recognize that their perspectives and efforts matter. Their caregiving work needs to be socially supported and should receive appropriate social recognition. Decent working conditions involve not only kind of adequate pay and social recognition, but also decent working conditions for paid caregivers involve enabling respectful relationships with them. So I managed to end in the time that I was hoping to end it. So thank you all so much. And your feedback is very welcome.
Well, thank you so much, Amy. I'll give you just a couple of seconds to catch your breath before we shift gears into the Q&A. So it's now time for questions and discussion. So if you have a question, please put it in the YouTube chat. If you're not logged onto YouTube or wish to ask a question anonymously, you may send your question to jcb.ea@utoronto.ca. The email address has been posted in the chat for those of you who are joining via YouTube. So assuming you've caught your breath, we'll start with this. Do you think that there's a role for advanced care planning when it comes to people with dementia?
So yes, Rashad, I do think there is a role for advanced care planning. I suggested that very, very briefly in one of my slides, even though I said I wasn't going to be focusing on end-of-life care. But advanced care planning isn't just about end-of-life care. Advanced care planning is also about the kinds of treatment that the person wants to receive while they are still living. I think that advanced care planning, including forming kind of advanced directives, can be very useful to substitute decision makers. It can be reassuring to think this is what the person wanted before. So that's one reason that it can be important. I think advanced care planning is also the only information that we'll have with people who are unable to express their preferences anymore, whether they're in a persistent vegetative state or they're just no longer capable of communication. So I think in those circumstances, advanced care directives are important. I think it's fair to assume that that the previous preferences of the person with dementia are going to be an important guide to what they might continue to care about. But I think we need to be open to evidence to the contrary. So that's, I guess, what I would say is that I think that advanced care planning can be useful, can provide kind of direction and support to substitute decision makers. And sometimes it's just the only information we have about the person's preferences. But when the person is capable of expressing their preferences, we should be open to the idea that those preferences have changed.
Thank you. Potentially a related question, maybe not. How does your view make space for persons with dementia wanting to make, let's call them bad decisions, or let's say even more broadly, against the advice of doctors or caregivers, say, for example, by continuing to drink red wine every day?
Okay, so I think that we need to give room even for people with dementia to make bad decisions. But I think that when we also need to be aware that they may no longer be capable of recognizing what some of the consequences of their decisions are. So there's a difference between respecting the decision of someone who's like, yeah, I know it's going to make my life shorter, but I don't care. I want to enjoy my life. And so I'm going to drink red wine. And you can say to them, because I have had this conversation, you can say to them, you know, that like an alcohol can exacerbate the effects of dementia. And if they're capable of understanding that there are consequences to their decisions still, right, and recognizing that, and they can remember that, then I think that we can recognize, we can respect those preferences. However, if they want to kind of leave, if they don't think that they need to be in a care facility, but they are no longer capable of taking care of themselves, they believe that they are still employed and are still capable of driving and so forth, and they are not, then I think that we're talking about circumstances in which the kind of their ability to be self-determined is radically undermined. And we can still attempt to kind of figure out something about kind of how can we still respect your authenticity? How can we still engage with you in a way that reflects what you care about? But I think that if they cannot appreciate at all the consequences of their decision, then it's not just a matter of they're making a bad decision because like they value, you know, the short term over the long term, and we think people should care more about the long term. This is a matter of them not understanding and appreciating the consequences of their decisions. So I don't know if that's a very clear response, but that's what I would say.
Excellent. Another question. Could you say something about how caregivers can know or be confident about care receivers' shifting capacities, maybe in light of so-called confabulations or false memories that enter relationships?
So I think that you often need to have access to more than the person's account of what's happened to them. And that's something I've learned in dealing with kind of people with dementia, is that you need to sometimes check in about, did this happen or did this not? If there's a lot of other signs that the person's memory is compromised, if there's a lot of other signs that they're not always kind of oriented towards the present, they aren't always aware of kind of when and where they're acting, it can be difficult to kind of trust them as sources of testimony. But that's not the same thing as figuring out what they care about, right? Because even the things that they confabulate will often reveal what's important to them. So I think there is a difference between you still being able to kind of figure out what someone cares about and regarding them as a reliable source of testimony about what's happened to them.
Great. We have another question. In the talk, you tended to talk about dementia, or perhaps the impression was dementia is something you either have or you don't. Does it make a difference to your view that there can be a slow emergence of dementia and a progress of dementia? And so maybe say something about that. How does that make a difference to your view?
Sure. So I did talk about sometimes kind of different degrees of dementia and kind of like, you know, like severe dementia or significant dementia versus. So I think that in earlier stages of dementia, people often are much more capable of assisted autonomy, for instance, than in very late stages. In the latest of stages, which I have witnessed, the person may no longer be able to kind of control, to even swallow, right? To control their gross motor functions, to express preferences at all. And so my views about, like, I'm not demanding that you attempt to kind of figure out the views of someone who is no longer capable of recognizing that they exist, of recognizing that others exist, of kind of communicating in any ways whatsoever. So I do think that there are degrees of dementia, and even and not only are there different degrees of dementia, but also people are very different in which capacities they lose and which capacities are impaired. So I mentioned that some people don't have their memory very significantly impacted, although most people do. And to count as having dementia, you have to have like more than one kind of area of loss. So I think it is very important because what I think is that you need to be attending to, like the whole notion of care respect is attend to the capacities and needs of the person with dementia, and they will be very different for different individuals and for those same individuals at different times. I also have noticed in my interactions with people with dementia that they can, sometimes abilities that you think they've lost can kind of be recovered at certain points as well. So if you're going to interact kind of with care respect, you really need to pay close attention to what is this person capable of now.
That's great. Another question, maybe tying some of the discussion together. How could a care provider approach a person with dementia entering a romantic or physical relationship in terms of previous values and altered capacity?
Yeah, so this is really hard. And I guess what I would say is that I do think that people should have the ability to start new relationships. And if an old relationship is no longer something that is available to that person in particular, then I think having a romantic relationship, even one that might be physical, could be appropriate. Now, they may be still married to somebody else, and they may be violating their marriage vows. But I think if they are no longer capable of recalling that they were married to somebody else, I think that is relevant. I do think there should be an opportunity for a kind of gentle reminders that there was someone else with whom you were very close. And kind of, would you like to have an opportunity to talk about that with somebody? Would you like to figure out how to say to this person with whom you used to be close, I'm sorry, I don't remember you anymore, or I don't have opportunity of interacting with you anymore, and I do have the opportunity for interacting with this new person. So I guess what I would say is that I think that the current capacities and the current preferences of the person with dementia matter. But I also think that their previous relationships often matter to them too. And so it can be kind of a delicate balancing act about what do you try to remind the person with dementia about relationships that used to matter to them that no longer do. And if someone is no longer capable of interacting with them, right, then maybe it is for the best to eventually let their memory of that person disappear and for them to move on to forming new relationships. But that's a really tricky one.
Thank you. There's another question here to the effect that how should a person who knows the person affected by dementia decide if they should let go of the idea of caregiving if they're being affected emotionally and physically?
Okay, so I think it's really important for someone who had a previous relationship to recognize that that in a just world, they would not be the only kind of way of the person with dementia receiving kind of support and having their needs met. And that if the person with dementia is not interacting with them in any kind of caring way in return, that I don't think they owe it to like the memory of who the person used to be or the memory of what the relationship used to be to put themselves in line for abuse. I don't think that is morally required or should, and I don't think that's something anyone should expect of themselves. I think that it might be easier for them to think about how can I, kind of still maintain a relationship, but one in which I'm not expected to do as much work, one in which I'm only an occasional visitor, one in which I give myself permission to leave when I'm not being treated respectfully in return, because it's very demanding work sometimes caring for a person with dementia, especially if you're one of the few people with whom they're still capable of having a relationship. So sometimes the person needs to step away and they can try again, but they really, I think, and there's people that they can talk to, including in kind of Alzheimer's society, have groups for people who are serving as caregivers, and they don't. And I know that the advice is not just that you continue no matter what, right? They need to kind of take account of their own needs as well. So I think that's what the question was meant to convey.
Yeah, I think so too. That's great. Got another excellent question here. Are changes in evaluative perspective always to be treated as, quote, change of mind, unquote? It sounds like you don't want to treat former values as having much weight unless the person still cares about them.
So actually, what I would say is that there's a kind of paper, I think, by a person called Alistair MacLean that talks about the kind of weight that previous values should have. And kind of he makes an argument that if adhering to those previous values causes the person to suffer, then we should kind of release them from them. But if not, then it can be a way of kind of engaging respectfully with someone. So even if they no longer recognize that they were previously a vegetarian, if they're not clamoring kind of to eat meat and kind of very upset about the idea of not doing so, then you could still provide them a vegetarian diet, right? But Monique Lanois gives an example of from a kind of a long-term care facility where she was on the kind of the ethics board, and a man named Oscar, who used to be vegetarian, now wants to eat what the other people in his care facility are eating, and it upsets him that when he doesn't get the same food as them. And so I think at that point, if there's no kind of damage to Oscar, then you can kind of honor his previous commitment to vegetarianism. But when it starts to actually kind of interfere with kind of his happiness and well-being now, then I think you have to let it go.
Great. I'm not seeing any more questions, so if I may, I'd love to forward a question. So you made a caveat at the introduction of the talk to the effect that for today we were going to be discussing not necessarily end-of-life care for people with dementia, but I wasn't sure if you wanted to say something about maybe how the conclusions of today's work have implications for something like end-of-life care for people with dementia.
So I did talk about the question about withdrawal or failing to provide life-sustaining treatment. So if a person previously indicated they don't want life-sustaining treatment, and there's evidence that the person continues to kind of find their life miserable, I think that the prior competently expressed wishes should obtain. But I do think that if a person previously said, should I develop dementia? I don't want anything. I don't want any kind of support whatsoever. There's two reasons to kind of have concern about that. One is if the person now says, I really, really want, I'm enjoying my life. I would like to get, can't you give me something for this cough? I feel like I'm getting sicker. I think that their their strong preference to continue to live and to receive medical care should be honored. And let's see what else. I had a second point, but I'm sorry, I'm forgetting it right now. Let's see. Let me think back to what I was saying. Sorry, I've lost the train of my thought there. But I guess I could say more broadly, more broadly, that I do think that the other thing I wanted to say is that people also often think that life of someone with dementia offers no more opportunities for growth, no more opportunities for engagement with interpersonal relationships. And so in the same way that people will often think, if I should acquire a disability, my life will have no value. People can think, if I should develop dementia, my life will no longer have any value. And they might be mistaken about that. I think it's important when we do develop, we engage in advanced care planning, for people to kind of point out, maybe you should know a little bit more about kind of the range of capacities people have in dementia. And so maybe we should have a discussion about, the kinds of capacities you might still have. Sometimes people also think that they'll say, if I can no longer recognize my children, I don't want to go on living. But then there's a kind of question about, what does it mean? So a lot of people recognize that the child going to visit them is someone that they love, but they forget their name. And they know that there's someone they love, but they might consider that to be their mother or their daughter or their sister or their friend. And so for me, I think that what does it mean to no longer recognize somebody? I think it would be probably to no longer recognize that you have a relationship with that person, to no longer kind of light up when they enter the room. And it's not just a matter of not remembering their name or not remembering the exact nature of their relationship with you. So that's sorry, I kind of went afar from the application to end-of-life decision-making.
That's quite all right. I asked a broad question, so that's the nature of it. All right, well, it's time to draw today's seminar to a close. So I have a couple of announcements to make before we thank our speaker. Our next seminar will take place on April 5th, featuring Dr. Jeffrey D'Souza on cervical cancer, vaccine equity, and global solidarity, fighting for the health of women and girls. To sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca, and this will be put in the chat. CSB students enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. Amy, on behalf of all of us, thank you very much for your presentation.
Thank you so much. I welcome questions, comments, criticisms.